Thank you very much, Janet, for that kind introduction, and thank you, Paul, for the invitation to join you today. So far we've had a number of talks that are really relevant to what I'm going to speak about today. I'll mention the prevalence and impact of cancer pain. We've had a lot on prevalence, so I'll briefly mention the impact. Talk about the evidence in cancer pain management and guideline development. Patient education and self-management is a key strategy, a central strategy, I would say, in managing cancer pain. Barriers to the implementation of evidence, strategies to implement the evidence, particularly around behaviour change, and that's behaviour change for our patients, but also behaviour change for ourselves, and evaluating that implementation. We've heard about how common it is. I think the point I really want to highlight in this talk is that the evidence for pain education and self-management has been around for a long time. Some of the key studies were done in the early 2000s, but still we as services do not routinely empower our patients by using tools to manage their own pain. This is work done by Fran Boyle and Victoria Potter, just showing the impact on function of pain greater than 5 out of 10. This is using the brief pain inventory, and we can see here this is pain less than 5 out of 10, this is pain greater than 5 out of 10. This is a scale where it's 0, mild, moderate, a lot, and total interference with those domains. And you can see that the difference is with general activity, mood, walking, working, relationships and sleep is huge between those two levels. And so we really need to pay good attention to this and help our patients to get their pain below 5 out of 10. One of the things that we talked about was, do we aim to achieve no pain? One of the questions we routinely ask in this studies is, in the studies that we're doing, is what is an acceptable pain score to you? Patients will vary. Some will say 1 out of 10, some will say 4 out of 10. This is the guideline Tim kindly showed in his talk, which we've developed. This is a synthesis of all the studies, randomised controlled trial and above, which talk to managing cancer pain. I'll show you here the address. It's readily updatable, and so if key new studies come to hand at that level, we will update the guideline. We've just undergone a process of linking with the Clinical Oncological Society of Australia, COSA, and we're about to put out an expression of interest for those who would like to participate in working groups for the different recommendations. So I would love to hear from everyone in the room to help us work to continually update these guidelines. This is the pathway, and today we've heard, so this is a synthesis of all the sets of recommendations into one pathway. You can see at the top here screening for pain, and strangely enough, after all this time, palliative care services are really good at it because we gather data for the palliative care outcomes collaboration, namely the SAS scores, and so patients do give us daily pain scores in our inpatient services. Cancer services in general are not doing this routinely, and we are in our implementation study of this clinical pathway, this is the control arm. So we are assuming that people are being screened for pain at every clinical encounter, and in fact what we're needing to do is implement systems by which people are screened when they come into clinic. One of the key areas is comprehensive assessment, and I do recommend going to the website and having a look at the details, because you actually cannot help people self-manage their pain until you understand some of the experience they've had, what their understanding is, and that is part of the comprehensive assessment. We've talked about communication. I'm going to spend some more time on that. Kat, on the pharmacological anti-cancer therapies we haven't talked about today, but absolutely central. And as we've reflected on the chronicity now of cancer survivorship, as people have anti-cancer therapy, we need to be very vigilant at then weaning down the pharmacological therapies, interventional and non-pharmacological management. Michael Nicholas talked about one theory of patient self-management. I'm going to talk about another one, and the reason I'm going to do this is to show the different aspects of both the patient, our own experience, and also the interaction between them. So each person has a biopsychosocial perspective. I would add to that spiritual, and I think we are, over time, understanding more and more about the real importance of the spiritual beliefs, practices, meanings and so on that people attribute to pain and by which people live. Patient as person, so someone who has agency both in their pain control but also in their seeking of support and information. Sharing power and responsibility. I think this and therapeutic alliance are things that we need to spend a little bit more time thinking about. We had recently here a placebo symposium where we thought a lot about how health professionals partner with patients in helping them in ways of thinking about their pain, mastery over pain, and different techniques to manage their own pain that are not pharmacological. And doctor as a person. So what factors influence person-centred care? Lots and lots of factors. And I think it's really incumbent on us to examine what we bring to our consultations, what factors, and read here health professional, because I think this, clearly we need multidisciplinary teams in good pain management. We bring our attitudes and our values. Our attitudes, and it's interesting, I have the privilege, as Janet and Katie and others do, of watching a number of registrars as they come through, and there is a real range in attitudes of, again I'm going to use that word, agency, of patients. We need to be really thinking about if we're going to be truly person-centred, we really need to be thinking and getting in the shoes of that person, their personality, gender, age, ethnicity, and knowledge of patient can all impact what we bring to those consultations. There's consultation level influences, communication barriers. Now they can be language barriers, but communication barriers are much deeper and more significant than just language. It can be coming from a whole different perspective. Interruptions, physical barriers. We all know the acute hospital, curtain between us. Time limitations. We did, as we developed this guideline, we went round to different professional groups around the country and talked about what were the barriers that they perceived. Time was number one. And in fact, I think we can all develop ways of really being very efficient while being generous, but being very efficient with how we use our patient interaction time and workload pressures. The shapers, the formal and informal learning, our medical training and clinical experience, and our professional context. My hope is that good pain management is going to become part of accreditation. That's a long game that I think many of us will need to work on. As part of the development of the guideline, we did a systematic review of patient education and self-management. I think, as we've already heard, there's really high level evidence that patient education makes a big difference. The crucial elements, when we broke it down in this systematic review, are things that enable people to be more involved in their own pain management. People that give, techniques that give empowerment, control, self-efficacy. One of the things that we, to my observation at this point, do not do across the country is have someone whose role it is to spend the dedicated amount of time that it takes. Now, I think one of the things we need to be thinking about is actually identifying who is really good at this in our various services, and dedicating time to developing these plans. And because it isn't something that happens on a one-off. Once you've developed trust with a patient, it actually can often take multiple consultations to chip away at some of the barriers that people have. The Managing Cancer Pain booklet includes, we have developed for the implementation of the guideline study and is available on the guideline. So I gave you the address earlier. There are on the guidelines a goal-setting tool. We heard earlier about the SMART goals. This is a tool that you can take to see your patients and develop goals with them. Doctors are telling us as we implement the study around the country that they haven't got time, so this is really something that our nurses, psychologists, pharmacists would be really well placed to do. There's a pain management plan, and the value of that is that you can take that, the patient and family can take that pain management plan to all the appointments at which they receive care. So often they see their GP, their palliative care nurse, their medical oncologist, their radiation oncologist, pain specialist, and so on. And take that around as a record. Apologies. A pain diary. I think the role of a pain diary, in my view, is for people to recognise patterns. Sometimes people feel so overwhelmed by the presence of pain that they actually can't start to take control of it. But a diary can help people see, okay, well, at 4 o'clock every afternoon, it must be, whether it's that I'm getting tired, or whether that's the time I've just done school pickup, or whether that's my Tarjan wearing off. That's the point in each day where I'm needing to take a breakthrough. So these are the resources that we're using to trial in this implementation study. I'm going to talk a bit more about the study shortly. So what are the barriers? The reason pain management is so hard, and I just acknowledge our colleagues who over time have really tried to implement these cancer pain guidelines in various settings around the world. It's a really hard thing to do, and it's hard because there are so many types of barriers. And so what we're trying to do in this study is address these barriers at different levels. There's health professional barriers. I think we all think that we do better than we actually do. And I would say one of the kind of pilot studies that we've done as part of this work is looking at a palliative care unit where we feel like we're doing this really, really well. And if we implement an education program around assessment for nurses, pain outcomes improved. So palliative care units as well can do better. Poor pain assessment. Patient barriers, these are real, we've heard about those today. The consultation level barriers we've talked about, and the system level barriers. And I think these are the ones that are the entrenched ones that we really need to be addressing, because if there's no system for screening for pain, well, the very first step to enter onto a pathway for managing pain isn't there. There's also a lot of lack of access to non-pharmacological strategies, as we've heard earlier. This is the other theoretical model that I want to mention to you, and this is the behaviour change wheel developed by Susan Michie. This is now used quite widely in implementation science to implement evidence where the evidence-practice gap exists over continues to exist over time. There's 3 domains: capability, opportunity and motivation, and you need all 3 for people to change their behaviour. Then there's functions: education, persuasion, incentivization, coercion, training, enablement, modelling, environmental restructuring and restrictions. And this is the theory that we're using to develop the tools to implement the guideline. So this is very busy, but I'm just going to highlight the patient education strategy. So you can see here at the education, we're using the Overcoming Cancer Pain booklet. Michael Nicholas showed that booklet. It's online, it's a hard copy available, and it of itself has been shown in a randomised controlled trial to improve pain outcomes for patients. These patient-held resources are using persuasion. They're sort of making a case for using pain management wisely and all the non-pharmacological. Here, incentivisation, it's going to improve quality of life. Down here, the improving caregivers and family to encourage reporting of pain and provide adequate support. The modelling, so the DVD, there's a DVD that goes with that Overcoming Cancer Pain booklet, and there's patients on there describing their experience and then modelling within that. and then again enablement. So you can see all those behaviour change functions are targeted by these self-management strategies. We're obviously also targeting health professionals and system level, because what we're hoping to see, and what we have seen actually at only one of the cancer centres that we're working, is routine use of these highly evidence-based strategies. Okay, so this is the study to implement the guidelines. It's a translational research project that I'm going to speak just briefly about. I wanted to point out that we've got a multidisciplinary team with nursing, oncology, implementation science. Louise is our statistician. We've got a health economist, and Tim Shaw is a professional education professor. We've got consumers, Beverly Noble and John Stubbs, GP input, and I acknowledge Katie is here and on the investigator team. Odette Sprite, who's done a lot of the work, is at Peter Mac, so acknowledging our Peter Mac colleagues, and we're working closely with Peter Mac at present to implement the guideline. So the aim is to evaluate the effectiveness and cost effectiveness of a suite of strategies designed to implement the Australian Clinical Practice Guideline to improve pain outcomes in adult outpatients in cancer in metropolitan, regional, rural oncology and palliative care settings. This is the design of the study. It's a step-wedge randomised control trial. These are the centres, 1 to 8, and we've got our last 2 sites coming on board now. Each site has a control phase, which is just the pain screening I mentioned, a training and intervention phase where people learn how to use the resources, learn more about the guideline, and receive feedback. So we're using Orton feedback. I think we've had a couple of examples of that in our talks already, where we look at adherence to the guideline at the centres and then feedback to the centres, and it's very, very powerful. Data really is powerful at changing behaviour. And then a sustainability phase, because we want this change to improve pain ongoing, not just for the length duration of the study. So it's oncology and palliative care outpatients with pain. The intervention, there's 3 that we're using. One's the Q-Stream Health Professional Education. That's an email-based strategy where we email cases. People answer them. Each case takes about 2 minutes. There's 9 cases. If they're answered correctly, the case is retired. If they're not answered correctly, then it's repeated until it's answered correctly. And there's key messages. The key messages are about 5 words long each, but our theory is, and this is actually it's an evidence-based strategy that's been used across different professional groups, doctors, so GPs and specialists, nurses, and so on, that doing what we know well is going to make a difference. The Orton feedback, as I've mentioned, the patient education and self-management resources, and supported by clinical champions. Now, I reckon that everybody here is here because you are a clinical champion. You have the power to change practice at your site by talking to your managers, suggesting ideas. You know, there's always a real, I think, hunger and support for quality improvement measures, and these are ones that can be implemented. The outcome is the probability of 30% reduction in the worst pain NRS, and the secondary outcomes are around mean and worst average pain, quality of life, patient empowerment, caregiver experience, and cost effectiveness. So we can all make a big difference in the management of our patients' pain, and I would suggest that empowering them and using your relationship with them to empower them to manage their own pain is the most important thing we can do. Thank you.
Thanks, Melanie. At lunch we were talking about various models of palliative care and about an integrated model where several centres now working absolutely alongside oncologists, and I think this is the way Paul did it in New York as well. And I know we often hear it say, so we work like that, right alongside oncology, and we often hear them say, oh, you've got pain, oh, just go and see the palliative care doctors, they'll sort you out. Do you think we're disempowering oncologists by doing that, and therefore that's sort of anti what you've been saying?
Yeah, that's a really good question. And the idea is that we need to actually empower our oncology colleagues, because palliative care cannot manage all the pain that's out there. And that's the idea of the education, the health professional education, and all the oncologists sign up for it, all the CNCs and so on. So the idea is to actually increase their capacity. At some centres, there's been a slight disappointment that we haven't been able to just kind of manage all the pain problems, but that's the fact. If it's going to be sustainable, we actually do need to upskill our colleagues, and we need to do it regularly. Yeah.
Do you have any resistance from patients? I've heard quite a few patients say, just tell me what to do. I don't want to understand. I just want to follow the doctor's orders. Do you find any resistance from patients in being given more responsibility for their own care?
Yes. Mainly not, though. Mainly patients really just have a real hunger for this and an interest in this. It depends on lots of things, as we saw in that model. Socioeconomic background, health literacy, previous pain experience. And another thing we saw in lots of these presentations is how many painful kind of experiences people have over time. So there's lots of things that impact it. Overall, people love it. Yeah, Peter was asking, is the information available in other languages? The screening tool that we use in the cancer centres is available in 6 languages. The actual patient resources are not. The idea is that once we've finished the study and we're showing some benefit from them, we will translate them. There are resources available in some other languages. Overcoming Cancer Pain hasn't been translated yet, though. Thank you very much.